Good morning. It's Thursday, August 13th, and you're with us at Ask the Doctor. The doctor's in, Ask Dr. Arwady. I just created that new title. The doctor is in, Ask Dr. Arwady. I'm Sybil Madison, your Deputy Mayor for Education and Human Services. I'm here with Dr. Allison Arwady. She's your commissioner for the Chicago Department of Public Health.
Good morning.
This is where you can get the latest on COVID-19 in Chicago and get your questions answered. You can put them in the box below. You can also send them to us through Facebook or Twitter using the hashtag AskDrArwady. We're going to check our physical distance. It's looking really good. Really important to keep that in mind, as well as keeping your face covering on when you are out and about in Chicago. Got to keep up those good behaviors and think twice about what we're choosing to do. Where do we stand this morning with data?
All right, so we have been in a holding pattern basically for COVID data for about the last week and a half here in Chicago. Just as a reminder for some context, the main number that we look at is just the number of new cases that we're seeing every day in Chicago. What is that average number of cases? That's the number we would really like it to be back below 200 cases a day. That's where we were sort of at our best. And we really don't want to see it over 400 cases a day. That would be the equivalent of 15 cases per 100,000 per day, which is where we've required other states to quarantine, et cetera. We have been hanging out right in that 300 vicinity, right in between the good marks of 200 and the bad marks of 400.
Right in the middle.
Right in the middle, and just holding flat there. So today, for example, we are at 299 cases per day on average. And over the last week, we've been anywhere between sort of the 290s and about 305, just holding stable. I like stable, but I like going down much more. And I would really, really like to see us heading back down, more firmly into the 200s and ideally getting back down below 200.
Yeah.
Of some concern is that the rest of Illinois has actually continued to uptrend even while we've been relatively stable here. And so Illinois is one of actually very few states at this point that is still seeing significant increases. And we've talked about, the state has been identifying these warning counties and places where there are major concerns for what COVID numbers are looking like. Those have at least to date, not been Chicago, not been Cook County, not been in really the Northeast. They've been more in some of the more rural or southern areas in particular. But nevertheless, very concerning.
Yes.
And I remain not pleased with where our data is. It's not an emergency, but it's also not heading the way I'd like to see. If we take a quick look at our other numbers here, so our positivity rate using that test positivity rate, the way the state calculates it, is at 5.1% today. Again, we'd really like that below 5%. 8% is where we get very concerned, but I want that below 5%. Our tests performed look very good. We're at 7,246 tests per day on average. You can see on this graph here on the right, we are well above our minimal testing target, but when positivity is up over 5%, one of the ways we really work on that is by trying to push additional testing, because that affects the denominator. So that's been, stably good. And if we look at the rest of our data here, deaths have been stable at 3 per day. That's actually been stable for weeks at this point. Right? Yep. Our person positivity, so as opposed to the test positivity, the person positivity, meaning only counting one test per person, that's at about 6.4%. And that's what we use, that's what we've been using historically here in the city, where we look at race ethnicity breakdown or geography breakdown, age breakdown. We only want to count one test per person. So either way, we have space to improve there for sure. But
and has 5 been our kind of goal for that one?
5 roughly is our goal. It's sort of, to me, it's kind of like, that 200 number is like, I would really like us to be below 200 and stay there. I would really like us to be below 5% and stay there. Because these are calculated a little bit differently, right? There's no magic place that is sort of considered good or not good. Lower is always better. So in New York, they've managed to get their percent positivity down to like 2%, 3%, and keep it there. I'd love to see us get there. So we're a long way from there, but we're also not, there are still parts of the country where that percent is easily in the double digits, and bad. So we're similar in both of these. I'd say we're in a sort of stable stable point of some concern, but not seeing major increases. And then importantly, not seeing these new cases hit the hospital system. So we watch really closely. I'll remind you, we track a lot of different numbers here, and we track the presentations of people with a COVID-like illness who come into the emergency department. So that's not waiting for testing results. That's just broadly, it's a very quick way of getting a sense, are people coming in with symptoms that could be related to COVID? Those numbers remain sort of at historic lows, since the COVID peak. Our hospitalization numbers remain low and in very good control. Our ICU numbers, our ventilator numbers, and then the deaths are all stable at the moment. And so that suggests that at least to date, we've not seen a lot of spillover from these increases of cases into the more vulnerable populations, people who are older, people who have underlying conditions. So that's good. Broadly making sure that where people are being diagnosed, that they're being careful, they're wearing their masks, they're not spreading it even at home. They're being especially careful, all of us, especially careful with folks who are at more risk for that hospitalization. So I've been pleased to see that so far. We know that can certainly lag, so we're a long way from out of the woods, but still reassuring that has remained relatively stable, and we've not seen further steep increases like we were seeing a little more of earlier in the month. So keeping a close eye on things.
All right. Oh, are you ready for questions?
I am
Doctor?
ready for questions.
Okay.
What do people want to know?
Julie Lawrence from Facebook. I tested negative, but had severe post-viral syndrome described the same as COVID-19 patients have had. Did I probably have COVID-19 or another virus? Did I test at the wrong time?
Okay. Good. Lots of interesting things in that question. So this
severe post-viral syndrome. I've never heard of that.
Yeah, so there's this post-viral syndrome. So we are still learning a lot about the longer effects of COVID. We know that there are people who seem to get COVID, have very minimal symptoms, or some people who have pretty severe symptoms who then seem to entirely recover and not have any issues ongoing. We do, though, also have some people who have had COVID and then have reported really some more ongoing symptoms, sometimes for a long time. And so this post-viral syndrome is still very much being described. We don't yet know how often it happens. We don't know if there are genetic or environmental risk factors that put people at more risk. You would assume that someone who's had a more serious illness would probably be more likely to have longer-term effects, but the bottom line is we just don't fully know yet, and it's an area of some concern. So to your question, generally where we think post-viral, again, it's been described in a lot of ways, but people might report a lot of fatigue, for example, or they might report, actually I don't even want to say, because there's been a range of things that people have been reporting, but basically not feeling back to normal after feeling sick. If you got, during the time that you had symptoms, if you got diagnostic tests, meaning the PCR test, the nose or the mouth swab, and it was negative, that's a pretty good test. Chances are pretty good that you didn't actually have COVID, to be honest. However, if you got tested, very early or maybe too late in there, as always, we've talked about, none of these tests are 100%.
Right.
If you really wanted to know at this point whether you had had COVID, she said it was June?
She didn't
say. So if it's been at least, a month, 6 weeks kind of thing since you had the beginning of whatever this was, you could get an antibody test through your doctor. That's the blood test that goes back and looks to see, do you have an immune response against COVID? If that were positive, then chances are good that what you had was COVID. If you got an antibody test and it was negative, particularly if you had diagnostic testing at the time and it was negative, I think it's very unlikely that you had COVID. If you're now feeling well, I don't know that there is actually a major need for you to know whether or not you've had it. But if you wanted to answer that question, the antibody test would be the best bet. But wait at least a month or 6 weeks afterwards to get that test if it's something that you decide you want to do. Either way, I'm glad you're feeling better. And we certainly will share as we learn more about potential long-term effects of COVID.
Okay. Ray Stout the fourth from Facebook. Is it safe to go back to the office with masking and social distancing?
Okay. So I feel like every time we do this program, I will never say something is safe or not safe. That is never an answer, because everything that you do that involves any interaction with another person includes some amount of risk. So we talk about whether this is a lower risk or a higher risk activity, and so much depends on, what is my personal risk factor? Am I severely immunocompromised? Am I, over 80? Do I have other concerns, right? So you can never sort of make a one blanket statement. But broadly speaking, what I would say is that we have learned a lot at this point about how to generally help make environments for COVID that are relatively safe. Not 100% safe, right? Not such a thing. But where we look back early in the outbreak, we were seeing quite a lot of spread in places where people were coming together, including workplaces, right? Like some of this got national attention, and we saw some of this locally here. Some large workplaces, particularly where you had people working closely together, assembly lines, factory lines, some of the food processing plants that got a lot of attention. And we saw quite a lot of spread in those settings. We have learned, I would say, actually quite a lot about how to protect people in work settings. And even I think about what that's looked like at the Chicago Department of Public Health, right? Like initially, we've continued working sort of through all of this, but as more has been learned, and for example, masking became so important, right? Like we wear masks, anytime you can't keep that 6 foot distance, we have people, you don't have to wear your mask if you're sitting, at your desk, but if you're up and around and moving, people are wearing masks. We've spaced out our lunchroom. We've put in, asked people to do symptom checks. We've, put a lot more hand sanitizer everywhere. We've thought about just the way people move through and the sort of equipment that we have. We've switched
the cleaning protocols,
upped all those. Like there's been a lot of work as we've learned about what is more concerning and less concerning to make office environments, as relatively safe as they can be. I think ventilation has certainly been another area of interest where large buildings have been working to turn over their air supply more often, bring more external air in. What filters are you using? Like there's a lot of things that you can actually do to continue to make workplaces as safe as they can be. So I can never say sort of 100% something is safe or not safe. If somebody still has a very serious underlying condition, even at the health department, for example, we are not requiring people to come to work in person, right? This is just, there's not a sort of one-off decision on that. But generally speaking, I think for people who do not have the serious underlying conditions and are going to be serious about taking the precautions, we are not seeing workplaces currently as being major sources of spread. We ask all of our contacts, where do they work, where have they been, et cetera, and we do investigations wherever we're seeing any potential clusters in workplaces. And again, it's not that it can't happen, but it's not like where we have, even if we have a single case, we're broadly not seeing a lot of spread in those settings. Doesn't mean it cannot happen. But I think compared to what we knew sort of at the beginning of this, I think we've learned a lot about how to keep people as safe as possible. I personally feel very safe coming into work every day.
I do too.
And I am careful and I take my precautions.
And we've been coming to work the whole time.
We've been coming to work the whole time, yeah. And I think, that is a part of it too, I think, that for folks who, and I want to be clear, I continue to be very supportive of teleworking and of anything that, if people are in jobs that allow them to continue to do that and employers can figure out ways to do that, I'm very supportive of that. Anything that just drops the amount of people that are moving around, of course, from a COVID perspective, I'm going to broadly be in favor of that. But I do think that if people have not been working in person, there is a lot of worry about returning to in-person anything. Yes. And in some ways, as you return to it, you sort of get to know what are the new protocols and sort of become used to it. We get our temperature checked every time we walk in the door downstairs at City Hall. There's a list of questions, and this just sort of is going to be the new normal. So I hope that sort of helps. I know it's not a like one-off. I can never say something is safe or not safe. But broadly, we have been very thoughtful. Employers don't want COVID any more than you want COVID, and so a ton of work with a lot of the industries and a lot of the employers around how to keep people really as safe as possible, and try to adopt settings that limit risk without completely eliminating it.
Yeah, you mentioned that we're not seeing a lot of spread in workplaces.
Yeah.
Where we are seeing spread is
In social gatherings. So yes, very, very much so. We're seeing it in households, and then we're seeing it when people are just getting together, not at a location, not at, a restaurant, not at a bar, not at a workplace, but in the backyard, in the home, in the birthday party. Like, we are just, and I do think that there is something to that. Like, this has been a really interesting outbreak to look at how the data's been shifting and then how public behavior kind of shifts with it. I think we perceive our homes to be safe broadly. We perceive the people we know to be safe. And yet, as we have expanded bubbles and been out and about more and having more contacts, there is the potential for people to pick up COVID and sort of bring it home. And so it's in these settings where people let their guards down in some way. I think that we are actually seeing more spread. People worry a lot about public transit. Public transit, where we look around the world and other places, has actually not been a major source, as long as it's not very crowded, right? As long as you can have the appropriate distancing and cleaning and all these things in place. But part of that is, I think, people really have it on their mind. If I get on the bus, if I get on the subway,
you're hyper alert.
I'm hyper alert. I'm really thinking about, I need to protect myself. Same with the grocery store. I'm definitely going to have my mask. I'm definitely going to be very careful. I'm going to wash my hands. I'm not going to touch my eyes, nose, mouth. I'm going to keep my distance. And we sort of let our guard down in settings that we perceive to be safer. But those individual risk behavior is what is really driving a lot of our outbreaks right now. And so just asking people to keep up the good work when you're around people you love. Those are the people who you least want to put at risk and who we most need to really try to keep that down.
So for Ray, his workplace probably has put in a lot of mechanisms to help keep people safe. It's about putting those mechanisms in in your social life.
Yeah, exactly. And it's much harder to do that. And one of the challenges for CDPH is that when you have a workplace or a long-term care facility or even the jail, we know who's at risk there. We can test everybody, we can follow them, we can put protocols, we can check it. We can't and wouldn't want to police your private gatherings. So it's really on individual Chicagoans to just keep being careful, especially protecting older Chicagoans. We're doing a good job with it. I mean, the data, the fact that we're not seeing that spike in hospitalizations is the thing that makes me the most pleased of everything in the data. And if we can keep doing that, we're doing okay by and large. I don't want to see COVID. I don't want, there's too many questions. There's too many, even young people can get really serious COVID. But we know how much riskier it is for older folks, and keeping them well protected is just key.
Yep. Okay. Joelle Jekyll Emmerich from Facebook. If you are considered a case but you have no symptoms, should one really be concerned about having COVID-19?
Okay, so that kind of plays into it's a good question. It's what we were just talking about. So first of all, if you have no symptoms, my biggest concern, and I hope your biggest concern, is that you are absolutely able, and probably just as able, to spread COVID to other people. So my biggest thing for you, if you're asymptomatic, first, I'm glad that you're asymptomatic, right? That's great.
We don't want anybody suffering.
We don't want anybody suffering. We don't want people unnecessarily sick. So on the one hand, I'm glad you don't have symptoms. But if you don't have symptoms, there is a much, my concern is greater that you are probably you may not be being as careful. If you have symptoms, I probably at this point, everybody's experienced this to an extent that you're ooh, I feel just a little bit off.
What is it?
What should I do? And hopefully in that setting, A, you're staying home, and then B, you're being extra careful around people.
It is the law to stay home.
It is the law. It is the requirement to stay home if you are feeling even a little bit sick in Chicago still. But nevertheless, so my number one concern is if you're asymptomatic, I am very worried about you because you have the potential to spread disease and not even know it. So right there, big concern. Yeah. And then secondly, to this point of the post-viral, hopefully if you're asymptomatic, that has very little implication for your life. But there are still some questions about that. And I don't want people to just assume that if I get COVID and I'm young and I'm healthy and I'm fine, there's never going to be a problem with that. Probably there won't be. I don't want to over concern people.
But we're still not.
But we're still learning about this virus. And, we learned from Ebola, there were people who could there were parts of the body that like Ebola could stay for a long time, and there was post-viral stuff that came out later. We are still learning about the long-term effects, and the more people get infected with this virus, the more opportunity there is for like weirdness, to be honest. Like the way that the virus interacts with individual people's genetic makeup, environmental makeup, all of the rest of it, there's more opportunities, frankly, for mutation. There's more opportunities for the virus itself to kind of spread and adapt. And so, yeah, I worry a lot about people who get COVID, even if they're asymptomatic. From a spread perspective, from a just general outbreak control, from the ability that every time the virus replicates, there's opportunity for mutation and change there, and that finally there could be longer term effects that we just don't know about.
Yeah. Here's a good one from Florence Caplow from Facebook. Is it true that most COVID tests are negative after 1 day from exposure? Does that mean then that people are not likely to be infectious 1 day from exposure?
Yeah, good. Yes, it is true that 1 day after exposure, most COVID tests are negative. This is one of the things that is the most challenging of this whole thing, is that the main diagnostic test we have, the PCR test, the nose test, the mouth test, is very sensitive, meaning it's very likely to pick up infection. It's a very good test as long as you do it at the right time. But yeah, 1 day out, even 2 days out, three, it very often the level of virus has not built up enough in your body. You probably are also not infectious at that time. That is also true. But again, there can be variability there. And so what we are broadly recommending, first of all, if you've had a really serious exposure to someone with COVID, if you get contact trace and you've been within 6 feet of someone who has had COVID, or you've otherwise been told you need to quarantine, like regardless of a test result, and you need to quarantine for 14 days, because remember, it can take that's the incubation period. It can take up to 14 days from the time somebody has been exposed for the level of virus to build up to a point where they can develop symptoms, have a positive test, and spread it. If somebody is wanting to get tested after exposure, we're generally recommending, with the testing that's available right now, waiting at least sort of 5 to 7 days, because most people, if you've been exposed, do tend to sort of have a level, have symptoms, whatever, in that 5 to 7 day period. But there are people who can go out at least the 14 days. So if you got that test at the 5 to 7 days and it was negative, you still have to quarantine for the full 14 days. Like it's just, that is just part of it. So did I answer the question?
You sure did.
Okay, good.
Yeah. Here's another one from Andrea J. Robledo from Facebook. I tested positive for COVID-19, but now feel better. Can I see my daughters already?
All right, good. So we're hitting on all the pieces of this. So I'm glad you're feeling better. Reminder, 99% of people who get COVID do recover, so that is good, and what happens to most people. So it all depends on the timing. Let's just talk about the timing of this. If you have been diagnosed with COVID, you need to stay isolated. We use the term isolated when someone is sick with COVID-19, and we use quarantine if you're not sick, but you need to stay separated. But they're the same idea. You need to basically stay home and out of contact with other people for 10 days. For 10 days from the time that your symptoms began, and your symptoms need to be resolving for at least 3 days. So the 10 days would be the minimum that you would need to stay in quarantine. But if you're still having fevers, you're still not feeling well, you gotta stay isolated until there have been at least 3 days with the symptoms, basically resolved. Yeah. And if you have questions about that, that's part of why we monitor people while they're sick and do follow up on them, et cetera. You'd wanna be talking to your doctor, you'd wanna be talking to the health department, the people who are following you. Once the reason that 10 days is there and symptoms resolving is that we have not seen evidence of people actually spreading disease beyond that 10-day mark unless they have continued to have symptoms. And so if someone doesn't have symptoms, we just use the test date as the beginning of that 10 days. But you can still sometimes pick up virus. This is important to know because this is a question we get a lot too. There are still some people who think they need to get a negative test to sort of get cleared. You do not. Employers do not require negative tests because if you go and try to do a swab, you may still pick up virus. The virus, kind of dead virus, right? Exactly. Virus that you are not spreading it to other people. It is not transmittable, but there can be sort of, if you think about, you kind of have snot for a long time. It's like that idea. You kind of have snot for a long time, but it's not infectious. It's not not sort of spreading it. So to use the colloquial term.
Yes.
So if you're feeling better and it's been at least 10 days and it's been at least 3 days that your symptoms are gone, you can see your daughters.
But if you're not,
you got to keep isolating. And if you've got questions about that, talk to your doctor or, talk to the folks who've been working with you on your case investigation and contact tracing.
Yeah, these different numbers of days can get a little confusing.
It is confusing. We thought about, I was sort of tempted to just say 14 days for everybody. But honestly, we do want to follow the science on this. I am a big, big proponent of taking what we actually know in the data and being honest about it and letting folks know what it is. And the data suggests that you can transmit for up to 10 days, but it can take up to 14 days for the symptoms to develop. Those are just different, and that is why we use those. So that's the basic answer.
Okay. Lee Clay from Facebook. I'm a type 2 diabetic. What are the signs of catching COVID-19? Am I quicker to catch the COVID-19 than most because of my type 2 diabetes?
Okay, good question. So let's take the second part of that question first. So if you have type 2 diabetes, or any kind of diabetes, or actually any of the underlying conditions that we talk about, that would be
heart disease,
lung disease, immune problems, etc. It's not that you're at higher risk of catching COVID. It's that if you catch COVID, you are much more likely to have a serious course of disease. You're much more likely to get more seriously ill, to potentially need to be hospitalized, or unfortunately to potentially die. I'll remind you, 94% of the deaths here in Chicago residents have been in people with those underlying conditions. So if you're a type 2 diabetic, I do want you to be especially careful related to getting COVID. But it's not that you are sort of more likely to attract it if you're in touch with someone. But if you are infected, you're more likely to get seriously ill. It's important if you have type 2 diabetes or any kind of diabetes to have that diabetes in as good control as you can, because this is in the same way I never say safe, not safe. This is always a little bit of a spectrum. People who have very well controlled diabetes are less likely to have the really serious outcomes than someone who has very poorly controlled diabetes. Again, it's not a one-off, right? These are all sort of matters of risk. But making sure that your diabetes, your high blood pressure, your asthma, your other conditions are in as good control as they can be it's good for your health generally, but it's especially good in the time of COVID. And so it's a good time right now to be making sure you're up to date with seeing your doctor, you're taking all your medications, you're trying to eat well, you're trying to get some exercise, you're trying to sort of be in a healthy place, you're quitting smoking if you're a smoker. Like, it's a good opportunity to be as healthy as you can be, particularly as we're heading, sort of into the cooler weather. And then to the first part of what are the symptoms? So the symptoms would also not be different in someone who has diabetes as they would be in anyone else. So still, the most common symptoms remain the fever, the cough, the shortness of breath. There are a whole host of other symptoms at this point that have potentially been associated with COVID-19.
As the list has grown over time.
As the list has grown, right. And so, we hear people just reporting feeling run down and feeling muscle aches. We hear people, complaining about joint pain. We've had some examples of, there are dermatologists there are people who have had problems with their toes that have turned out to actually be, in some cases, related to COVID infection. We've seen a whole host of things present, which actually is not that different from other viral illnesses. Yeah. The bottom line is, though, you feel sick. Yeah. And if you are diabetic or any other underlying condition and you start feeling sick, even if you don't have that fever or cough yet, we want you to take that seriously. We want you to get a COVID test. And if you have an underlying condition, we want you to be in touch with your doctor. So yeah, nothing has actually changed in terms of those leading symptoms, but we certainly have had plenty of people who have kind of had this range of symptoms. And again, the more people get COVID, the more opportunities there are for it to kind of present in slightly different ways.
Yeah. I'm just noticing that you answered Valencia Thomas's question, because hers was, is it easy for me to catch COVID with asthma? Yeah. And you just explained
Same thing. It's not that it's easier for you to catch it, but if you were to get it, you would be at a higher risk of getting more sick from it. So keep your asthma in good control too.
Yep. Raymond Manasia from Facebook. If one ingests food that has been coughed or sneezed on, can you become infected?
Okay, so we've answered variations on this question a few times before, but I know people still have questions about it. So Food is not thought to be a route of transmission broadly for COVID. The Food and Drug Administration, if you're interested, go to the FDA. There's all kinds of information about the details. But the bottom line is, when things go into your mouth, they can either go into your lungs or into your GI tract, your stomach and your intestines. And if you swallow food that someone has coughed on with COVID, it actually will generally go into your stomach and the acid will kill it, and it's not going to be a major problem. However, say someone's been sneezing and coughing on the food and you're, touching the food or around the food and you're not washing your hands, and then you're touching your eyes, your nose, even your mouth potentially, there is some relatively low, but some potential there for spread, which is why, thinking again about reducing risk, we've moved away from things like communal salad bars, right? It's not so much as something on the food, but where you're touching you're everybody's using that same spoon to pick it up, and there may be something. And again, it's more like, are you letting those germs into your respiratory tract in some way? So I don't have major concerns about food. I really don't. Yeah. It's more just the setting in which you are otherwise sort of interacting with that food.
Right. That's a good point, because if someone is sick and they're touching things, so one might think that it had some association with the food, but it probably is all the other behaviors.
Yeah, exactly. Yeah. So, I don't know where that question's coming from exactly, but I think, again, I don't have major, we've gotten variations of this question around, like, when people drop off if I order food in or my groceries, you don't need to be doing a lot of grocery washing and food washing and all of that. Just please wash your hands and do all of the safe food prep that you otherwise would. Cook your food thoroughly, do all of those things. If you do that, food is not a significant concern. Always, what do I say? Interaction with living, breathing people is your biggest risk factor by far, above all of this. Fomite is the term for touching things. The risk is still there. We want to be careful about it, but it is lower than the risk of the interaction with individuals.
Okay, Margaret Quinn from Facebook. Governor Mike DeWine was in the news last week due to a false positive test result.
Right.
Can you speak to test accuracy and your thoughts on whether percent positivity should still be an indicator that will impact economic and school reopenings, et cetera?
Okay, so lots of things in that question too. But it's a good question. All right, so that was the governor of Ohio, in case people missed it. He was supposed to meet with President Trump and got a test that was positive, and so obviously did not meet with the president. And then that same day had a follow-up test that was negative, and then a couple of additional follow-up tests that were all negative. So I was, of course, interested in this, so I looked into the details. It's interesting. The test that he had that was a positive test is actually a kind of test we've not talked a whole lot about here. It's an antigen test. So, not to go too kind of off the rails here, but the main type of diagnostic test, this PCR test, the main nose and mouth tests that have been, they're very good tests. They're very sensitive. Again, if you do as long as you do the test at the right time. But they're very expensive tests, and there's been a lot of work to develop quicker, cheaper tests. And so most of those quicker tests have still been the same PCR technology. So if you hear about ID Nows or some of that, that's the same technology. That's still PCR. But antigen tests are a totally different kind of test, and they're using the immune. They're looking for, instead of looking for the DNA virus, the RNA of the virus itself, they're instead looking for sort of pieces of it. It's a different technology. We won't get into all the details right now, but it's a newer technology that is quite a bit less expensive. And the thought is that if you can deploy it much more broadly, it will be very good, sort of on a population level. But it does have a little more of the false positives and the false negatives than this PCR testing. So I'm still very gung-ho on antigen testing. I don't want to say that it's not something that we're interested in, because we are. We're interested in anything that brings the cost of testing down, makes it more accessible, brings it into different platforms. But it highlights that for any of these rapid type tests, when they come positive, if there is a significant concern, we sometimes will actually have people go and do a follow-up sort of gold standard PCR test.
It sounds like that's what he did.
And that's what he did, exactly. So I don't think he had COVID. I think he truly did have a false positive, which can happen. Now to the second
impact on our positivity
right.
rate.
To the second point of the question. So antigen testing is not widespread like at all. Like there is very little antigen testing happening at this point here. We would get a positive antigen test just like we would get other tests, but the bulk of the tests, like I don't have the exact number. I can actually, this is an interesting question, so I'll ask the team. But my guess is at least 95% of the tests that are coming in are the PCR, diagnostic tests, just because that's what we broadly have available here in the Chicago area. And those remain very good tests. Percent positivity is extremely helpful because when testing is sort of relatively stable in an area and you see that changing, it really is one of the most sensitive ways to know what's happening with an outbreak. So we, for example, as you know, with the Race Equity Rapid Response team, we look every single week at where are we seeing increases in percent positivity, like at a neighborhood level, because that suggests, if you've had pretty stable testing numbers, but the percentage that are positive is coming up, that actually lets you know that there is more spreading in that area. And so it's one of the main things that we really look at when we're trying to, direct resources. So, there is kind of as in many things of COVID, there is not usually one thing that we look at. My number one, and the one that we have really led with, is that case number. It's the one that I like the best. You can't fudge it. It's the number of positive cases that are diagnosed. Percent positivity, though, is sort of a really important secondary component that is crucial, and we use it a lot. I am not concerned about it getting thrown off by a few sort of false positives or negatives. What can change it is the fact that the way that we show both ways of counting it, the test positivity like the state does, and the person positivity that we do for more of this focused research, but focused intervention. But at the end of the day, it is very helpful. It's just only one piece. The other thing we look at is how quickly cases are rising or falling. If we are seeing very rapid increases, that is a much greater concern and something we need to act on much more aggressively than the sort of slow meandering like we've been seeing. And then finally, are we seeing impact on hospitalizations? At the end of the day, we start threatening the healthcare system. We have to be very fast and aggressive to not let that happen, particularly as we're moving into the fall season. So there are always, look at all, we've had, let me get the total here. 698,639 tests done in the city of Chicago in 510,671 people. So that's the difference between people who have had, positives. When you test 500,000 people, there are going to be, some occasional things like this. But when you're doing this volume of testing and follow-up, that amount sort of comes out in the wash, and it's consistent over time. So I'm very confident in our data and in our epi work here. I've got a whole team that looks through the electronic lab data that comes every single day, that gets rid of anything that's questionable, that gets rid of double tests, that counts things properly.
Hours the data.
Like hours and hours and hours and hours every day, making this data here in Chicago absolutely the best that it can be. And therefore, I feel very confident using it to be able to make decisions about, what we need to do, where we need to direct resources. A strong epi response is only as good as the data that it's based on. And it's why we have very much emphasized this and why we make it so publicly available, right? Like that data dashboard, chai.gov/COVID-, that's the same data that our epis are looking at every day. So I encourage you to explore it.
All right. Dolores Santillan Cerillo, do we need the vaccine if one has already had COVID-19? What side effects might this vaccine have? And could we pass down any of these side effects to future children or fetuses?
All right. Lots of good questions today, and multi-questions within a question. All right. So,
do we need the vaccine if we've already had COVID-19?
Very good. So, the bottom line there is probably yes. We, again, are still learning about COVID and its immunity. But one of the biggest questions has been how long immunity lasts. And Probably that answer will be different for someone who has had some natural immunity after COVID exposure versus a more predictable immune response that can come with a vaccine. So I can't 100% answer that question at this point because we are still, the studies are underway, et cetera. But my sense is that we will be recommending probably universal vaccination. If we were not going to recommend universal vaccination, probably instead you would need to be getting a titer, it's called, which is a immune, like for example, chickenpox, right? Like there is now a chickenpox vaccine. We vaccinate kids against it, but people who are older and had chickenpox when they were younger, as a healthcare worker, I needed to get a titer, meaning a blood level that looked and said, yes, I actually had chickenpox and have a high enough immune response to it that I am protected and I don't need to get the vaccine. Titers are expensive and a pain and trickier to interpret. For this one, my broad expectation is that we will be making universal recommendations. There probably will be some people that will have medical exceptions, like to get to the larger part of this question. It is too early to know. We talked about on Tuesday that vaccine trials are very much still underway. The phase 3 trials are going now in the US for the earliest candidates. And the point of those trials is to look for side effects, is to answer exactly these questions. And there are special testing and sort of follow-up components for particularly vulnerable groups, which would include pregnant women, which would include children, which would include probably people who are older. And so the reason that the first stages of vaccine testing are all done in like young, healthy people by design. And then as we sort of are able to see that a vaccine is both safe and work, we expand the population that testing is done in with very close monitoring for any sort of side effects, for any kind of follow-up. And it's why, again, it's too early. We'll have to see sort of how this plays out. But I doubt that pregnant women or children, frankly, will be in the very first round of vaccine availability. We'll want to make sure that very good safety testing has been done for those populations. We have to be absolutely confident when we back a vaccine that all of the appropriate safety and efficacy testing is done. And this is where I was not real pleased to see Russia, for example, start doing some vaccinating of people before the trials are done. I think that is, that makes me very uncomfortable because I worry if you start seeing side effects or problems in that population, what effect that can have. Every country makes its own decisions, and we have a strong vaccine regulatory platform in this country that will absolutely be following this. So good questions, and certainly as we start to get closer to a vaccine, we'll be able to talk more about the details of what side effects have they seen. At this point they've seen, for example, sore arm is a side effect we can broadly tolerate, right? Perhaps a small fever you might be able to tolerate, but you start seeing more serious issues, that is not a vaccine that would ever be approved.
Yeah. All right. That was our last question from Dolores.
Good questions today, people.
Yes, very good. We got through a lot too. Just some good news.
Yes.
Really quickly, I'll say our One Summer Chicago program is our summer youth job program out of the Department of Family Support Services. It is this year the largest summer job program. Chicago, fortunately, was able to preserve a lot of jobs. I think about 21,000 young people had worked for the last 6 weeks. Many of it virtual, but a lot of our partners adapted what they were doing so that in this environment, young people could work and be safe. And 2,000 of that 21,000 are our very first Chicago Youth Service Corps. So these were young people who raised their hands, signed, and said, I want to sign up to do something to contribute to our response to COVID in the community. So these 2,000 Chicago Youth Service Corps members graduated this morning. I was able to be a part of the graduation. And it was really wonderful to see. And they did all kinds of things. They did PSAs on COVID, which I hope that we'll be using. We're going to share them with the communications team. They made masks. They did photography around COVID. They did oral histories with our seniors. Just a number of service projects all related to COVID-19 and helping people deal with COVID-19 this summer.
Yeah, and one of the pieces I'll chime in that I was sort of the most pleased about were the ones in this group that were our social distancing ambassadors. So we've gotten a lot of questions even here about, what are you doing to enforce masks and social distancing? So these were 14 to 24-year-olds who have been out this summer, sort of through the Parks District. They've been out in parks, in their neighborhoods, but also along the lakefront, along other places. They got some training in sort of outbreak response and control and epi training, which is pretty cool. But then they've been out, wearing their vests, wearing their hats, distributing masks, and then just being, politely asking people to put on their mask, to socially distance. And I had a chance to meet with some folks earlier in the week, and broadly, people listen. You approach people with respect. I think especially younger people, frankly. It's a really good approach, and we're hoping to continue this kind of engagement. I am much more interested in engaging people around why they need to do the things that help keep everybody safe than I am in, strict punitive fining type measures. I want people to do the things that work because that's how we all protect each other. That's how we get through this. And so, props to the social distancing ambassadors and to the whole Corps, and really, to the more than 20,000 youth who have really been stepping up this summer.
Great news.
All right, that was excellent good news. I think that'll be
that'll be it.
That was good enough news for everybody for the
enough.
day. Absolutely. Fill out your census if you haven't, please. They moved the end date on that. We were supposed to have until the end of October to finish filling out the census.
We have one less month now.
I will note that the end of October is very close to Election Day, and perhaps for political reasons, there was a decision to shorten that time to the end of September. I am not happy about that. Chicago is running under national averages in terms of getting that census done. Health department needs census numbers to be able to have accurate health data, but much more importantly than that, it is how our city gets funding, it is how our city gets representation, and it is so important. If you lost your card that came in the mail, you don't know your key, doesn't matter, you don't need it. You go to the census webpage and you just put in your address, they'll find it for you. 5 to 10 minutes, do it today if you haven't.
All right. Well, we're going to sign off now. We'll be back on Tuesday at 11.
And next Tuesday we have a special guest, Massimo Piccilli, who leads our testing efforts at the health department and knows everything related to labs and testing and what we're doing, so he can answer more of these kinds of questions. Will be our guest on Tuesday. So, but obviously we'll take questions of all kinds, and in the meantime we'll keep doing the one-off questions every day. So keep sending them in. And thanks for watching.
Think twice, reduce your risk.
And be safe, Chicago.